Hello, everyone. We would like to share our screen. We share the screen. Yeah. Okay. Alan, can you see our screen?
Yes, I can see. Yeah.
Thank you. Okay. Hello, everyone. My name is Tassawan Poomchaichote. I am a project coordinator for the project, and my colleague Ravikanya Prapharsavat. Hi. We are from MORU, Thailand. The project that we are doing is about community engagement for AMR in Thailand, funded by Welcome Trust. And today we are going to present on behalf of the team. First, we would like to introduce our partner, which are Drug System Monitoring and Development Center, Civic Net Foundation, and Food and Drug Administration Ministry of Public Health, Thailand. These are MORU team led by Professor Pek Yong Chia. Our team had a variety of people from different backgrounds, such as public engagement coordinator, medical anthropologist, and social science communication. Antibiotic use in Thailand in 2018, human consumption is around 2,500 tons, and livestock and agriculture consumption is approximately 3,800 tons. If we look at the human consumption by year, we will find that in 2018, we used antibiotic more than 2017. So it looked like the trend of using antibiotic may be high as antibiotics are easily to access and cheap for both human and animal. Today, to address AMR problems, Thailand had the first national strategic plan on AMR in 2016. It comprised of 6 strategies. Our project integrated with strategy 5 to raise public knowledge on raising on AMR and raising awareness and appropriate use of antimicrobial. Thai campaign have focuses on raising awareness through education and event, but less on public involvement or engagement. So we have this project to engage AMR stakeholders, policymakers, and members of public. The activity that we have done in the project, we follow Welcome Toolkit Responsive Dialogues. The toolkit help outline activities, design, plan, and run the dialogue so we can develop these the ideas and solutions into policy and strategy. The project objective are to co-create an engagement strategy and to co-create context-specific solutions relevant to local communities. The findings from the project will be informed and provided as recommendation to support the next Thailand National Strategic Plan on AMR. The project activity, we have 3 phases to implement. Phase 1, we call planning dialogue. Phase 2, community dialogue. And the last one is phase 3, feedback to AMR stakeholder. Phase 1, we conduct in-person meeting with 2 full days. This phase, we want to align the project with National Strategic Plan on AMR, policymakers, and AMR stakeholders, which include author of Thailand National Strategic Plan on AMR. Phase 2, community dialogues. There are 2 types of this phase. First one is national virtual dialogues that look at national issues. We conduct the session in both adult and youth virtually. Second is in-person regional dialogues, which look at regional issues. National adult virtual dialogues gave opportunity to Thai people who were unable to join in-person meeting to discuss and co-create solutions to address national AMR issue. Next is about National Youth Virtual Dialogues. We conduct this event in conjunction with Antibiotic Awareness Week 2021. This event was to engage young people across Thailand to co-create solutions for their own age with focus on communication and online platform. Moving on to the last activity of phase 2, which is regional conversation. That is still ongoing. We have been conducting this phase at in-person meeting with 3 full days in the 4 regions of Thailand. The invite participants include farmers, villagers, healthcare workers, and many people from all walks of life. We consider the potential participants based on local context and problems. For example, in southern Thailand, their community have variety of culture, which include Muslim community. So we invited this group of people to join the dialogue. There are some photos from the regional dialogues. We use small group discussion and fishbowl activity to identify local problems and co-create solutions to address AMR issue in their regions. Next, I will let my colleague Ravikanya talk about how a dialogue setting is and preliminary result. Gail, please.
Hi, thank you very much. So for the dialogue setting, we follow the welcome responsive dialogue toolkit design and have set our agenda to be of the 3 points: identifying the problem, ideating the solution, and co-creating the solutions. For identifying the problems, we start off with asking participants to share personal practice, experience, as well as observation towards pharmaceutical consumptions in their family, relatives, or community. We ask them to reflect on their antibiotics use and identify the problem. An example of the activity that we have done is called fishbowl activity. This is where the participants sit with experts, policymakers, and people from the implementation level from their area and discuss about AMR problem that they faced and how to solve it. An example of the questions in the session that the facilitator have asked was, why did the National Action Plan in Thailand does not work? For ideating the solutions, we ask people in the community about how can they relate AMR problem to the rational drug use and the primary healthcare system in Thailand, and also how can we embed AMR literacy in the existing primary healthcare system. Lastly, we asked the participants to co-create a 1-year action plan to tackle AMR with their area, such as in their sub-district that they are from. So we will ask them to think about what is the key success for communication there and how can we link their plan to the primary healthcare system and then to the quality of life development at their district level, and especially without causing more work to themselves and other staff. So throughout our dialogue conversation, we found some gaps and made some recommendations that we have planned and sent out to the national policymakers, which is the Ministry of Public Health Thailand. So for AMR communication, one major problem in Thailand, which is the misunderstanding between antibiotics and anti-inflammatory. This caused Thai people to use antibiotics for very minor and simple illness, such as sore throats and headaches. There's low awareness on the issue as there is no research on effective communication. The media content itself is, I would say they say it's not dramatic enough as it does not aim at any target audience at all. For recommendation, we understand that antimicrobial are not easily understood, as many did not know that it include antifungals, antiparasitics, antivirals. For the first part, we do recommend healthcare providers and experts to use consistent terms in order to reduce that confusion. We also need to reach wider set of audience by increasing variety of media channels and exposures, where the AMR content should be simple, clear, but at the same time kind of dramatic and interesting enough for lay people to remember. For public engagement on AMR, some of the gaps include how people at the grassroots level still does not know about it because of the limited reach to the wider audience, as well as the limited impact on level of behavior changes or raise in awareness. This is because there are fixed or hard to change beliefs about antibiotics use. Next, there's a lack of representative or lack of faces or examples, for example, like patient groups or leader where audience can identify AMR with. We also recommend to establish the definition of AMR and its related sickness. People should understand the foundation of AMR before introducing other topics. Existing networks should have platform and media channel that fits with the people from different generation. For example, online platforms worked really well with youth. To change the behavior of the audience, it is also important for them to take ownership in the solution that they work for. They should feel empowered when the solution is established so they can be motivated to implement. Last, when we talk about AMR, we should give a lot of examples. For example, AMR cases in hospitals or the information which should also be given back to the community. People can relate to the emotion of the AMR survivors or cases, which will make them become more aware and related to the dangers of AMR. Some of the challenges that we face can be categorized into two parts, which are virtual and in-person. For the virtual one, digital literacy plays a major role in how the project plays out, especially people who cannot navigate their way around functions and breakout rooms. There's not much opportunity to network. Therefore, the co-creation solutions are not as concrete because from online, you cannot really see them in action. There are also challenges in power dynamics. For example, having experts and non-experts in the same room, some participants are hesitant to speak out. As for the on-site with the COVID restriction now, there are a variety of demands and sometimes it's very hard to fulfill all of them. There are also participants from many backgrounds, which is sometimes very hard to communicate about AMR, especially to get them to understand AMR in the same level as maybe a healthcare provider who's also a participant. But the networking and the teamwork really does help with that. And lastly, there's also a problem in power dynamics where participants are also hesitant to speak out. So to date, we have conducted 12 sessions with approximately 200 attendees. People in the community really give good insights to the problems where we could further identify the gaps and recommendation that could be included in the National Action Plan. We have also found that empowering people who are in the community or works in the community can be effective in moving the project forward, and that it is important to give special attention to the people in the implementation level. Lastly, to communicate policy with the implementation level effectively, we should provide the 4 M's. So this one include methods, managing, materials, and money. So lastly, we have recently just submitted the report of the preliminary findings to the authors of Thailand National Action Plan. As a direct result of the conversation, there have been some community-led activities already. Our participants came back and have integrated AMR topics in their jobs from the plan they have created in the workshop, such as setting up AMR programs in informal schools and elderly schools, as well as discussing about AMR in village health volunteers meeting. So these are some illustrations that have been drawn by our MORU team. We want to illustrate the behavior patterns of antibiotic misuse that we have learned from the community dialogue. So I would like to explain a little bit. So the mobile grocery ones. So this one is in the village in Thailand, there are cars that sells basically everything, and they would just go in the village and people in the village would come out and they would ask for drugs or antibiotics. The second one is the local grocery. So this one is established everywhere in the community of Thailand, and they sell really, really cheap stuff. So some people would, some community who doesn't have money, sometimes they go there and they just be like, oh, I have this amount of money. Can I have at least just only 3 pills? And of course, the seller is not a pharmacist, so they would happily give them. So we would like to acknowledge everyone here for their help and collaboration. And lastly, for the information on this project, please go to this link or scan this QR code. Okay, thank you.